to get to talk to some of my nursing colleagues about a topic I'm really passionate about and talk to such an experienced group. And at the end of my talk, we should have lots of time for discussion and questions. So I hope I also get to take advantage of your experience and knowledge and learn a bit from you. So thank you very much to Haley Lane for the invitation. So I'm going to be speaking about status epilepticus, and this is going to be an evidence-based approach. So probably almost all of you have managed patients in status or having seizures, and I want to take some time to talk about the evidence and why we do what we do. So my goals for today are to talk about the definition of status epilepticus, what we're talking about, and when we need to move from oh, it's a seizure, I'm a neuro nurse, I got this, to, oh, this is an emergency and we got to get things going. The first stage of status epilepticus, which we define as the first 5 minutes, and what the critical actions and treatments are in that phase. Stage 2, when your first round of medication, your benzos, hasn't worked, what the heck are we going to do next? And then stage 3, when it seems like nothing is working to get your patient's seizures under control. And then last, we're going to talk about difficult status, I would say. So not all seizures shake, and we're going to briefly talk about recognizing and considering non-convulsive status. So to start with some epidemiology, status is the second most common neurologic emergency after stroke. The annual incidence is about 30 cases per 100,000. So that means we're seeing a good number of cases in an average year in the Calgary area. And status carries a significant mortality. So depending on the case series or publication you read, the mortality for all comers is estimated as 7 to 20%. So a very significant condition. To talk about the definitions for status, first, garden variety status epilepticus is defined as a convulsive seizure lasting more than 5 minutes or 2 seizures between which there's incomplete recovery of consciousness. So if you have a patient who had a seizure and then kind of doesn't come back to their baseline and then seizes again, that needs to be treated as status. Status becomes refractory when a patient has gotten an adequate dose of benzodiazepines and another anti-epileptic medication, and they're still in status. And that's either clinical convulsive status or status on an EEG. We get into super refractory territory when status has continued or recurred 24 hours or more after an anesthetic has been started. So that should only be happening in the ICU. So that's for our neuro ICU nurses. So keep those definitions in mind as we run through the stages of status. Status is an emergency, and that's because there are better outcomes and better drug efficacy when we treat early. We know that our medications we use for status are more likely to stop seizures the sooner we give them. And so that's why there's urgency to starting treatment. We also know that the longer status goes, the more lasting damage there is to the nervous system, and the higher risk of complications such as hemodynamic compromise, airway compromise, et cetera. So that's why we need to get the show on the road when a patient is in status. We won't talk too much about pathophysiology in this talk, but there are some important physiologic changes that occur in status. So status, as you all know, is massive synchrony of neurons firing together. So you can get excitotoxicity from massive amounts of neurotransmitter release simultaneously. And then in the first even few minutes of status, one of the really clinically important changes that happens is that there is downregulation of GABA receptors. And that's a critical transition because most of our first-line medications for status are benzodiazepines and others act on GABA receptors. So we really want to take advantage of those receptors while they're available because that's part of why status becomes harder and harder to treat as it persists. So that's why we want to hit people up front with benzodiazepines. In terms of the causes of status epilepticus, there are myriad causes, all of which you will see on the average neuro unit. And each cause portends a different risk of mortality and morbidity. So the most common cause of status is low concentration of anti-epileptic drugs And we see this a lot, non-adherence to medications or other reasons that patients may have low concentrations. So that's about a third of status cases, and that portends a 4% risk of mortality. So that's still a high rate of mortality, but contrast that to something like an anoxic injury. That's only 5% of status cases, but that portends a 71% risk of mortality. So that's a very severe and concerning presentation that portends a pretty dire prognosis. So I like to think about status in terms of those stages of management and what I need to do at each time point. These definitions do have some pathophysiologic and evidence basis. So the way we think of status is there's sort of the time one point, and that's the time at which seizures are likely to continue if there's no intervention. Most seizures will stop on their own within 2 to 4 minutes due to inhibitory mechanisms. But status is when those natural inhibitory mechanisms have been overcome by the seizures. And so that's why we use that 5-minute mark, because a seizure that hasn't stopped on its own by that point probably isn't going to stop without treatment. So that's when we need to take action. The next critical time point is the time 2 time point, which for convulsive status is pegged at 30 minutes. And that's where we start to get into risk of long-term consequences from status. So in animal models, that's where we start to get irreversible evidence of neuronal damage and neurotoxicity. And patients can have very severe complications at that point. So ideally, if we get our treatment started early, we can try to avoid getting to that point in status management. And so this is an evidence-based talk. And so the best evidence for status is actually for the early stages of status. So those first 5 minutes, first 20 minutes stages. And then as we get into refractory and even super refractory status, it's more of an evidence-free zone. So we're going to spend relatively less time on those and talk about where we have good evidence for the upfront treatment, because I think that's what's really critical for us frontline folks to know. And as we get into those further stages, stage 3 and 4, that's where we get into more off-label medication use, creative medication use. And unfortunately, that's where we also get into greater morbidity and mortality for our patients. So ideally, if we can, collectively optimize our management of stage 1 and 2, hopefully fewer of our patients are getting into stage 3 and 4. So to first talk about stage 1, or that first 5-10 minutes, I want to talk about the evidence for what we use first line. So this is a really nice study that was done in the Veteran Affairs with thousands of patients in the United States. This is not new evidence, but I think it's important to know. The study's from 1998. And so this was looking at successful treatment in convulsive seizures and comparing different anti-epileptics to see what was most effective for seizure cessation. And as you can see, between phenytoin, diazepam plus phenytoin, phenobarbital, and lorazepam was the winner here with a dose of 0.1 milligrams per kilogram, leading to cessation of about 65% of seizures. So this is a big part of why lorazepam IV is our go-to first medication when we're treating someone who's going into status. We often have the scenario on the ward where a patient goes into status and we say, oh, we don't have an IV, or they've blown their IV. And as the people on this call will know well, trying to get an IV in a patient who is convulsing is an Olympic sport. And so there's actually some good evidence to forego trying to get an IV if your patient is seizing in front of you. This is a study that was done with EMS in a pre-hospital setting. And they looked at differences in time to administration and whether seizures were stopped by the time patients got to hospital, comparing IV lorazepam and then IM Midaz. And as you can see, for IV lorazepam, it took almost 5 minutes to get the medication in, which I actually think is pretty impressive. And seizure cessation by hospital arrival was 63%. But if you just go IM, The time to administer is just over a minute, and 73% of patients had seizure cessation by the time they arrived at the hospital. So time is really of the essence. So if you've got a patient where you don't have reliable IV access, IM is potentially the way to go. And this is something that I learned from Haley. So in terms of the best IV or the best IM site to go after, vastus is fastest. So that big juicy muscle in the anterior thigh is a really great site if you're giving a IM dose in the context of status. Something to be aware of and that I think you can be an advocate for if your prescribers are shy about their dosing is there's very good evidence that benzodiazepines are often underdosed in the context of seizure. So as you know, the typical dose that is recommended in status is 0.1 milligrams per kilogram of lorazepam. And you'll commonly see that even for someone who's 32 kilos or a lot more than 32 kilos, we'll start with 2 milligrams and sometimes not follow that up with another dose. Whereas those patients should be getting much higher doses. In a study including over 1,000 patients in Europe, that was a prospective registry where they just collected status patients and looked at how they'd been treated. The vast majority of patients, 76%, got less than 70% of the recommended benzo dose. And that has really practical implications for our patients' outcomes because in this sort of real world data set, 70% of patients were still seizing at 1 hour. And that's a huge difference compared to RCTs, where patients always got the correct dose of benzos, where only 40% of patients would be seizing at an hour. So making sure that we're getting an adequate dose in those first minutes is really critical. I think one of the reasons that as prescribers, we can be gun shy about giving an adequate dose of benzodiazepines is we're always worried about the potential harms of our treatment. And particularly when giving benzos, we worry about causing cardiorespiratory compromise and potentially needing to send our patient to the intensive care unit. So this is one of my favorite data points that I tell everyone about. This is a really nice study where they looked at lorazepam and diazepam compared to placebo. And this was again in a pre-hospital setting. And they looked at the rates at which patients required respiratory or circulatory support following treatment. And so respiratory support was defined as someone requiring bag mask ventilation or intubation. And circulatory support was patients who became hypotense, requiring intervention, or went into a cardiac dysrhythmia. And they found that there was a signal towards placebo, so not actually treating with benzodiazepines, having a higher rate of cardiorespiratory compromise compared to giving benzodiazepines. So as they put it in this trial, our data are consistent with the finding that intubation is more commonly a sequelae of continued seizures than it is an adverse effect of sedation from benzodiazepines. So I think that's really important for all of us to be aware of. The seizures are more likely to cause need for intubation and an ICU stay than adequately treating them. So to summarize that first 5 minutes and the evidence for management, we want to give our medications early. We know the faster we get them in, the better they're going to work because there's those hungry GABA receptors there to interact with the benzodiazepine. If we don't have an IV, that's when we want to think about going IM with midazolam. And we want to make sure that we are giving adequate doses. So don't be shy. And just to review the doses, for midazolam, it's 0.2 milligrams per kilogram with a maximum of 10 milligrams per dose. Lorazepam IV is at 0.1 milligrams per kilogram. And per the AHS guidelines, that maxes out at 8 milligrams. And they recommend giving at a rate of 2 milligrams per minute. Diazepam, which I see used less commonly, is 0.15 milligrams per kilogram. So we're moving on up to stage 2, so benzo-resistant status epilepticus. So this is sort of after our first 10 minutes and when we need to move on to second-line agents. So these are the common second-line agents that are used: phenytoin, fosphenytoin, VPA, phenobarb, and levetiracetam. And I'd be curious if people just want to throw in the chat what they see as most commonly used on their units in their practice as the preferred second line agents, and if they have any particular pet peeves for the agents that they see used. In terms of the guidelines kind of leave it as a choose your own adventure for what second line agent to use. So these are the Neurocritical Care Society guidelines. These were last updated in 2012, but they're still in use today. So they sort of say any of these are reasonable to use: phenobarb, valproate, levetiracetam, or a midazolam infusion, which would certainly be less common on a non-ICU unit. And then the American Epilepsy Society has very similar recommendations. So I don't know about your guys' units, but what I see used most commonly is phenytoin, both in the emergency room and on the neuroscience unit. I think phenytoin has been the standard in many places. It's one of our older medications. It's sort of a classic, and it's something that a lot of us are more comfortable with because it's been around for a long time. But I wanted to talk about some of the potential pitfalls to be aware of with phenytoin. So first of all, it is a medication that needs to be infused slowly at 50 milligrams per minute maximum. And it also has a prolonged time to peak effect. So from starting the infusion to the peak serum concentration is about an hour. So phenytoin can be slow when your patient is in status in front of you. As many of you know, phenytoin has poor IV compatibility with other meds, and particularly cannot be mixed with any glucose-containing solutions due to risk of precipitation of the phenytoin. Phenytoin has a ton of drug interactions. It's a potent CYP inhibitor. And so there are many medications that it wreaks havoc with and affects the metabolism of. In general, we're moving away from using phenytoin as a outpatient treatment for epilepsy or a maintenance therapy. And that's due more to long-term issues with it, including cerebellar atrophy, gingival hyperplasia, and osteoporosis and bone thinning. So your patient is less likely to be discharged on this medication than they were maybe 20 years ago. Drug-induced seizures are less common on our neuro units, but phenytoin as a sodium channel medication can be harmful and potentially ineffective in drug-induced seizures and carries a higher risk of arrhythmia in that context. And my last phenytoin pet peeve is that we commonly underdose that, and that is certainly our bad as prescribers. So some local data, at a retrospective study at the University of Alberta Hospital, only 18% of patients received the recommended dose of phenytoin for status, which is 20 milligrams per kilogram. A third received less than 1 gram of phenytoin. And that resulted in patients being much less likely to reach a therapeutic level within 24 hours when they got a dose of less than 15 milligrams per kilogram. So this is very common, and as we discussed, has implications for whether we're adequately treating status and how long a patient's status goes on for. So this may be something to nudge some of your prescribers about and remind them what the patient's ideal body weight is. Another downside of phenytoin, you might be wondering why there's a picture of an airplane here. So what's used to de-ice airplanes? It's propylene glycol. Propylene glycol is also the vehicle for phenytoin when it's given in a parenteral form. And it's responsible for a lot of the side effects that we all know and love for a patient who's received a loading dose of phenytoin. So patients being confused, somnolent, hypotensive, maybe a bit bradycardic or going into an arrhythmia. That is in large part due to the propylene glycol toxicity that we may be exposing them to with a high dose of phenytoin. So something to be aware of. At the start of this section on part 2, I mentioned that there are many agents that are available in the guidelines to be used. And until recently, we didn't actually have good evidence to look at equivalence or differences between these medications. In 2019, this trial was published in the New England Journal of Medicine, and this was a randomized trial of 3 of our big anticonvulsant medications and status. This is the ESET trial. So this was a randomized blinded trial of 3 medications, looking at folks over 2 with benzo-refractory status, so people who had progressed from stage 1 to stage 2. There were a few precipitants of status that were excluded, including trauma, hypo and hyperglycemia, arrest, or post-anoxia. And the doses they used in this trial were Keppra 60 milligrams per kilogram up to 4.5 grams, fosphenytoin 20 milligrams per kilogram, which is a phenytoin equivalent, and then valproate 40 milligrams per kilogram. And the main outcome they looked at here was the absence of clinically apparent seizures and improving responsiveness at 60 minutes after the start of the infusion without requiring additional medications. So I think this is a pretty good real world study, though I would not want my patients to be in status an hour later to find out if the medication worked. So when we look across the outcomes for these 3 medications, we see that these numbers are very similar. So the percent of patients who had the outcome of interest, so seizure cessation at 60 minutes, was just under 50% for all 3 of these medications. When we look at the safety data for this trial, there were some adverse effects, including respiratory depression and hypotension. But there were no significant differences between these 3 medications, the Keppra, phospheny, and VPA. So this is another way of demonstrating that data, the probability of treatment success for each of these medications. They all result in about 50% chance of seizure cessation at 60 minutes. So the way that I interpret that is that each of these medications are equally likely to work if they're given at point A in the seizure management algorithm. So what I would favor is giving whatever you can give the fastest and what's available instead of delaying to get something from pharmacy. So as a sidebar, something that was actually changed after we ran a status simulation on Unit 112, which is our neuro step down unit at Foothills. We said, we really like giving Keppra because it doesn't have all of these side effects of a phenytoin load, doesn't mess with other medications, doesn't cause respiratory depression. But we didn't actually stock Keppra on our units. And now we do, thanks to the work of our clinical nurse educators. So now we have more options for management of status. Okay. When we get into stage 3, which is refractory status epilepticus, our benzos haven't worked and our first line anti-epileptic has gone in and still the patient is seizing. This is our stage 3. This patient's been seizing for about 30 minutes. And so things are getting pretty dire. These patients are hopefully not on the ward at this time. These patients likely have a ticket to the intensive care unit. And so certainly by this point, if they aren't already involved, I would be involving our critical care colleagues for additional support because our 3rd line management and status is largely infusions of medications, including midazolam, propofol, phenobarb, or ketamine. And so these are not things that we are, of course, running on the ward. These are typically patients who are going to need airway plus minus hemodynamic support to tolerate treatment, and also likely need continuous EEG. I'm going to leave a further discussion of these medications and 3rd line status management. Happy to answer any questions, but this is a very evidence light zone. So I will leave that now. To move on to non-convulsive status, not all seizures shake, and I think non-convulsive can kind of be a specter on the neuro wards because it's very challenging to diagnose and assess for. So I think of convulsive status as the tip of the iceberg, and then if we look a little bit deeper, beyond those obvious seizures that are hard to miss, there are more subtle forms of status that we can encounter. One is epilepsia partialis continua, also known as focal motor status, if you're not trying to sound too fancy. So this is when there is ongoing seizure activity in part of the brain that's leading to focal motor seizures. So your patient may have twitching on one side of their face or tonic-clonic movements of one arm. And there are patients who can be in focal status for days, weeks, even years, depending on the etiology. So it doesn't have to be just bilateral tonic-clonic seizures to be status. So that's something to be aware of when you're on the wards. Because it is focal, there is evidence that it is sort of less harmful to the brain overall. So you will see that this sometimes is not treated as aggressively as we would treat a generalized bilateral tonic-clonic status. Then even murkier still, we get into non-convulsive status epilepticus without coma. So these patients can be very tricky because they can seem like a patient who's delirious or a bit confused or a little bit off for no clear reason. And then we throw an EEG on them and we realize that they are having seizures all of the time. And then probably the most difficult one is non-convulsive status epilepticus with coma. So these are our patients who are obtunded, unresponsive, and don't have any overt motor manifestations to clue us into the fact that they're in status. So I think of those as sort of the bottom of the iceberg because they can be really tough to identify. Similar to our discussion of convulsive status epilepticus, the evidence is best for our management of convulsive status. And as we get into non-convulsive status, we get into a lot of eminence-based practice and a lot of opinion without a lot of evidence for how we manage these conditions. And as a result of that, I'm going to focus just on some of the evidence for recognizing non-convulsive status, because I think that's really the critical step. When we think about the urgency of treatment and the risks to our patient for each of these conditions, a single seizure we're not too worried about. We manage them all the time on the neuroscience unit. Convulsive status is, of course, on the other side of the spectrum where it is an emergency and has huge morbidity. For non-convulsive status, we know that it can cause harm, particularly if it's protracted, but there's less clear evidence about when harm begins and how rapidly we need to treat it. So it is more of a gray zone in the seizure management world. So how can we recognize non-convulsive status? In a meta-analysis that was published in the Lancet Neurology in 2016, they looked at the most common symptoms that portended non-convulsive status. The major player here was altered mental status, which was 82% of patients. And that could include anything from memory loss to confusion, lethargy to coma. About 15% of patients presented with speech disturbance, so an aphasia, dysarthria, or otherwise. Myoclonus was seen in 13%. 11% had unusual behaviors. 8% had anxiety, agitation, or delirium. 7% had upper motor neuron or extrapyramidal signs, and 6% had hallucinations. So I'd ask you to think back to your last shift and ask if you had any patients who didn't have at least one of these findings, and you'll see why it's so challenging to have the right index of suspicion for non-convulsive status. It can look like just about every other condition we manage on a neuro ward. So we do need to keep it in mind and keep it under consideration. This was a nice study where they looked at the sensitivity and specificity of different factors in predicting non-convulsive status when the patient got an EEG. And they looked at recent risk factors, which included acute intracranial events, drug intoxication or withdrawal, and anti-epileptic non-adherence, as well as more remote risk factors, so kind of a baseline risk factor, such as prior stroke, tumor, neurosurgery, dementia, or meningitis. Those had a sensitivity each of about 75%. Specificity for recent risk factors was pretty low. If a patient had tonic-clonic activity prior to their unresponsiveness, they had about a 50% chance of having non-convulsive status. And the two that I thought were most helpful were looking for subtle ocular movement abnormalities. So nystagmus, gaze deviation, or other abnormalities that had a sensitivity of 50% and a specificity of 86%. So that can be a good clue to think about non-convulsive status in your bedside assessment. And then also looking for subtle motor activity. So a little bit of twitching around the face or a little bit of twitching in the hand. That had a sensitivity of 75%, but only a specificity of 44%. Not everything that twitches is a seizure, but it is something to keep your antenna up for on our units. So this is just a summary of the guidelines. I keep this available all the time while I'm in the hospital to easily refer to those critical steps and critical doses. And I think it's really valuable to think about things in terms of that first 5 minutes of status. What do we need to do and have ready? And then once we've done, that stage 1 management, moving on to getting our anti-epileptic in as fast as we can. And then at that point, we're getting our intensive care unit colleagues involved and considering whether our patient needs airway support, infusions, and ICU level care. So the take-home points that I hope people get out of this talk are first, recognizing when your patient has gone from a seizure that we manage every day to a medical emergency. So that's that 5-minute mark of convulsive seizures or 2 seizures without coming back to baseline in between. Being aware of benzodiazepine dosing and that we have really good evidence that we need to not delay benzos and we need to not underdose. So please be an advocate for this if you see that your prescribers are shy about their dosing. Being aware that our second-line status medications are equivalent in terms of their efficacy and overall safety profile. So give what's available fast. And finally, not all seizures shake. Keep a high index of suspicion for subtle seizures and non-convulsive status. When your patient has some of those subtle alterations in their mental status, twitching, eye movement abnormalities that can't otherwise be explained by their condition. That's what I wanted to share with you guys. Thank you for your attention, and I'd be very happy to take some questions and have some discussion. Thank you.